Good afternoon. Today I'm going to speak about a very critical issue, which is drug prescription and the kidney, the art and responsibility. As physicians, we are responsible about drugs that we are going to prescribe. And today I'm going to speak about this issue under these points. So I start with introduction, followed by some pharmacological points, then diabetes and hypertension, what's new, checkpoint inhibitors in transplantation, some new updates, publications, and then final messages. To start with, this is the Voltaire statement. Doctors are men and women who prescribe medicines of which they know little, for diseases about which they understand even less, for people about whom they know nothing. So we should exhaust ourselves. We should know our patients, taking good history, listening to the patient, examine the patient, know in details the drug and drug interaction. And nowadays, it is an easy task to use even smartphones to know drug interactions. Regarding the pharmacology behind the common drug nephrotoxicities, the nephrotoxicities are either related to the drug and the kidney, drug itself, or the patient-related factor. So, regarding the drugs, kidney is an organ which is subjected to increased exposure to drugs. And the drugs may lead to immune phenomena, like proton pump inhibitors that affect the kidney. Sometimes we use combination of nephrotoxic drug, like methotrexate with non-steroidal or S inhibitors or aminoglycosides. So we should be careful because this will increase the nephrotoxicity. Or using drugs that lead to crystal formation because they are insoluble, like acyclovir. Or the drug, increasing drug concentration within cell because of transporter competition, like cisplatin. Or intracellular drug accumulation, or even the drug may lead to a specific cluster formation like vancomycin, or direct nephrotoxicity by aminoglycosides. So all these are drug-related factors. Some patient-related factors like age, gender, allergy, alter the pharmacogenetics, renal disorders, metabolic disorders, or volume disorders. So we should be careful whenever we prescribe medicine is to examine the patient to know the status of the drug given and to assess critically the risk of nephrotoxicity. In general, in the pharmacology, this is an interesting chapter about adverse drug events, medication errors, and drug interactions. So drug interactions and drug reactions are classified into A, B, C, D, and up to F. So A is reaction occurring because of the dose. So it is dose related or augmented. So this means that it is common and can be predicted, like hepatic failure with acetaminophen using a large dose of acetaminophen, or aspirin and metabolic acidosis, or side effects from the drug, like nausea, headache with methylxanthines, oral thrush with steroids, nephrotoxicity with aminoglycosides, or secondary or indirect effects like phototoxicity with doxycycline or diarrhea with the use of antibiotics, or using antibiotic increasing other drug levels like macrolides. So this is the type 1 reaction, dose dependent. Type B, it is hypersensitivity. This means it is not dose dependent and it is unpredictable. So like intolerance, tinnitus after single dose of aspirin, idiosyncratic reactions like hemolytic anemia in case of glucose 6-phosphate dehydrogenase deficiency, azathioprine therapy toxicity in patients with thiopurine methyltransferase deficiency. This is why it is recommended to know thiopurine methyltransferase genotyping before given azathioprine. Pseudo-allergic reactions Immune drug reactions, allergy, like anaphylaxis from beta-lactams, photoallergy, and etc. So this is type B reaction, non-dose dependent, unpredictable. Type C, side effects or drug effect that is time dependent, delayed, related, and time related, or chronic, like osteonecrosis of the jaw because of the continuing use of bisphosphonate. Type D, delayed reaction, leukopenia with lomustine, which can occur up to 6 weeks after a dose. Type E, associated with drug withdrawal, like what happens after withdrawal of benzodiazepines, insomnia, anxiety, and perceptual disturbances. Failure of therapy failure due to substandard or falsified drug products. So all these are drug effects. Adverse drug reactions are classified according to severity into mild, moderate, severe, or lethal. Lethal means it can cause death. And we can know through this algorithm and can predict the adverse drug reaction. So we have questions, and for each question we have the answer either yes or no. So we give a score for each question of these 10 questions, and at the end of the day, if the score is above 9, this means that drug reaction, adverse drug reaction, is definite. If it is 0, means doubtful. So this is a score of predicting adverse drug reaction probability. And the medication errors are classified into no errors, or error but no harm, error and harm occurs, or severe errors that lead to fatal situation. So an error occurred that resulted in patient death. Drug-drug interactions. I think it is an easy task today to know drug-drug interactions. Just put it on the internet or using a smartphone or special sites like Liverpool drug checker of drug interactions. All these facilities facilitate knowing drug-drug interactions. This is a funny drug interaction of cola-containing drinks. I put this slide because whenever we are asked by the patient, or whenever the patient has a special habit, we should think and review literature and read in details for each drug, if there is an interaction with this habit or not. So cola-containing drinking habit may be associated with many drug interactions, leading to reduction of level of lithium and warfarin. So reducing the effect of lithium and warfarin, and increase. So the use of cola-containing drink increases methotrexate level, either delayed elimination or reducing excretion and increasing accumulation of methotrexate. Also, azole antifungal drugs increase, ketoconazole and others, ibuprofen, phenytoin. This means that cola-containing drinks have their interaction, even if they are reported in case reports or small studies. So we should be careful, even when we prescribe medicine, even with foods. In our practice, we advise patients to take tacrolimus on empty stomach because this increases the absorption of tacrolimus and reduces the cost by 30%. This is the antimicrobial. This is the risky combinations. Antimicrobials and other drugs, these are contraindications. For example, if the patient is treated with quinolones, levofloxacin, gemofloxacin, moxifloxacin, ciprofloxacin, ofloxacin, norfloxacin, and others, here we shouldn't use amiodarone, broconamide, quinidine, or sotalol with these combinations. Why? Because if you prescribe these quinolones with this antiarrhythmic drug, this will lead to torsade de bois. So this is a catastrophe and may lead to mortality. So we should review any added medication. Is it suitable or not? Contraindicated or not? Even here, everolimus and sirolimus, because we are interested in immunosuppressive drugs, to not to be given with erythromycin, clarithromycin, because this will lead to bone marrow suppression and hypokalemia. Even antibiotics may lead to urinary stones. Why? Because antibiotics interfere with oxalobiome degrading bacteria on the gut microbiome. And this will increase the availability of oxalate, leading to oxalate stones. So the advice is, the message is, we shouldn't prescribe antibiotics except if they are extremely indicated, because they may be associated with side effects, raising resistant strains, or even today I'm speaking about urinary stones. Again and again and again, to stop abusing antibiotics. Regarding diabetes and hypertension, this is a nice clinical practice guidelines for treating diabetes in older adults in 55 pages. I recommend this guidelines to be read. And this is a table from these guidelines using medications, their use in older patients, their use in patients with chronic kidney disease, stage 3 or to 5, and their use in patients with cardiovascular disease. So we can consider it as a nice review for anti-diabetic medication. So if we look at insulin, insulin in elderly patients can cause hypoglycemia. In patients with CKD, there is a decreased clearance of insulin. So it increases risk of hypoglycemia. Dosage may need adjustment. Consider giving rapid-acting insulin postprandially because of gastroparesis associated with diabetic kidney disease. It may worsen fluid retention in patients with cardiovascular disease, so to be cautious with TZDs. Regarding metformin, can cause gastrointestinal intolerance in elderly patient, may cause vitamin B12 deficiency, but doesn't cause hypoglycemia. What about the use of metformin in chronic kidney disease? Again, reduce the dose to 1 gram if estimated GFR is less than 45. To be stopped if estimated GFR is less than 30. Stop if increased risk of acute kidney injury, like the use of radiocontrast dye, hypotension, sepsis, shock, or hypoxia. May be beneficial in patients with coronary artery disease. Avoid metformin use in patients with severe congestive heart failure to avoid lactic acidosis. Regarding the metformin in chronic kidney disease, if we use metformin, we should look at the dose and monitor the patient well. Sulfonylurea in older patients can cause hypoglycemia, can cause weight gain. Avoid glyburide. In chronic kidney disease, avoid glyburide if estimated GFR is less than 60. Glimepiride, avoid if estimated GFR is less than 30. Glipizide, use with caution if estimated GFR is less than 30 ml per minute. For patients with cardiovascular disease, can cause hypoglycemia, which is to be avoided because of potential arrhythmia and stroke. Regarding glenides, can cause hypoglycemia in older patients. Glipizide, use with caution if estimated GFR is less than 30 ml per minute. Natiglenide, stop if estimated GFR is less than 60. Can cause hypoglycemia if there is cardiovascular disease, which is to be avoided because of potential arrhythmia and stroke. TZDs may be useful for individuals who skip meals, don't cause hypoglycemia, can increase fracture risk in older patients, can cause fluid retention, can cause weight gain. Here, rabaglanide in CKD, use with caution if estimated GFR is less than 30. Although there is no need for those adjustments, but we don't like to use them because of risk of fluid retention. It can increase fractures. Here in cardiovascular disease, pioglitazone has been shown to reduce cardiovascular disease mortality, can cause fluid retention with potential to worsen heart failure, so to be considered. DPP-4 inhibitors Alpha glucosidase inhibitors don't cause hypoglycemia, but lead to gastrointestinal side effects and may cause non-adherence. If there is chronic kidney disease and creatinine above 2, avoid the use of alpha glucosidase inhibitors. DPP-4 inhibitors does not cause hypoglycemia. And these are the different members, and the dosage for each one of them was different GFR, sitagliptin, saxagliptin, allogliptin. For linagliptin, we don't need modification. Saxagliptin has been shown to increase the risk of heart failure. So it's just simple, basic informations about anti-diabetic drugs. For sodium glucose cotransporter 2 inhibitors, doesn't cause hypoglycemia in older adults. Empagliflozin can reduce cardiovascular event and the progression of CKD. Volume depletion adverse effects more common in older patients. Canagliflozin may increase fracture risk, has also been associated with an increased risk of toe and foot amputation, may rarely cause ketoacidosis. Regarding the use in patients with CKD stage 3 to 5, canagliflozin estimates GFR between 45 to 60 to be given 100 milligram, below 45 avoiding use. Dapagliflozin to be avoided if estimated GFR than 60 until we have recent studies or publications from the current studies. Empagliflozin to be discontinued of estimated GFR less than 45. Empagliflozin and canagliflozin have been demonstrated to reduce major adverse cardiovascular events and congestive heart failure. This is a fantastic class of drugs. GLP-1 glucagon-like peptide 1 receptor agonists doesn't cause hypoglycemia, may cause gastrointestinal side effects. This is the doses. Exenatide to be avoided if estimated GFR is less than 30. Liraglutide, dulaglutide, semaglutide, they need no dose adjustment needed. Lisinatide, avoid if estimated GFR less than 15. Use with cautions in CKD regarding bromocriptine. Here, liraglutide and semaglutide have been demonstrated to reduce major adverse cardiovascular events. So it is a very nice review for drugs, their use in older patients in CKD and the cardiovascular disease. What about Ramadan? This is the first Canadian position statement about diabetes and fasting Ramadan. And here I'm going to focus on drugs and Ramadan fasting, because in Ramadan fasting there is absolute fasting. Regarding drugs, this if the diabetes is controlled by these drugs, bigonide, metformin, DPP-4 inhibitors, metformin combination, alpha glucosidase inhibitor, TZDs, all these drugs need no change while fasting. So these drugs need no change. Regarding the use of other classes, they need special consideration. So this is the class of drugs, sodium glucose cotransporter 2 inhibitors. Here, recommend dose, reduce dose, or hold temporarily prior to fasting for those with high risk of dehydration. For those aged above 75, estimated GFR less than 60 ml per minute, or the recent use of loop diuretics. So if there is a risk of dehydration, don't use these drugs or stop them. Don't hold dose for those with clinical cardiovascular disease and stabilized on these drugs. Don't initiate within 4 weeks prior or during Ramadan. So 4 weeks, because we want the patient to be stabilized before allowing fasting. Hold for vomiting, diarrhea, or orthostasis. So these recommendations are considered when we think of the use of sodium glucose cotransporter 2 inhibitors, or if we use sodium glucose cotransporter 2 inhibitor and metformin combination. Regarding glucagon-like peptide 1 receptor agonist, no change if tolerating prior to Ramadan. Don't initiate within 4 weeks prior to or during Ramadan. Reduce the dose or hold for nausea, vomiting, diarrhea, or orthostasis. Exenatide should be taken before meals, before 2 meals. Exenatide should be taken before sunset meal. Longer acting agents can be taken anytime. So these points should be put in consideration when we prescribe drugs. Like, what about insulin? Basal insulin, Degludec, Detemir, Glargine. All these preferred options consider reducing dose of these medications by 15 to 30% for the fear of hypoglycemia. Regarding NPH, consider switching to longer acting basal analog or reduce the dose by 25 to 50%. Again, the risk of hypoglycemia. For short acting insulins, Aspart, faster Aspart, Lespro, here preferred option, take usual evening meal dose at sunset meals. Reduce the pre-dawn meal dose by 25% to 50%. Omit lunchtime dose. For human regular insulin, consider switching from human regular insulin to rapid-acting insulin analogs. For pre-mixed biphasic insulin Aspart, human insulin mix, here consider switching to an alternative regimen, basal insulin oral agent, basal insulin, GLP-1 receptor agonist, basal insulin plus mealtime bolus insulin, or basal bolus insulin taken with each meal, depending on patient and the agent level characteristic when feasible. If continuing, reduce the pre-dawn meal dose by 25 to 50%, take usual evening meal dose at sunset meal. Medications that may need to be adjusted or changed due to the risk of hypoglycemia. Glimepiride, consider switching to an alternative drug class with lower risk of hypoglycemia. Glimepiride, if continuing, consider switching to a safer agent within a class with lower risk for hypoglycemia and reduce the dose by 25 to 50%. Repaglinide may be safest because it is ultra short in this class. Adjust according to alteration of mealtime and sizes during Ramadan. The most important advice is to monitor diabetic state well, monitor glycemia through Ramadan, and the risk of hypoglycemia is fatal if we leave the patient to fast. So if we have hypoglycemia, we should break fasting. Let us make to shift to an important and rare, sometimes rare complications, which is euglycemic diabetic ketoacidosis. The most important risk factors for occurrence of euglycemic diabetic ketoacidosis with the use of sodium glucose cotransporter 2 inhibitors is preoperatives. So surgery is a risk factor. So we should stop them before surgery and to be left after surgery for a period of time until we are sure that the patient can receive a regular meal. So what are the precipitating factors for sodium glucose cotransporter 2 inhibitors induced euglycemic diabetic ketoacidosis? Intercurrent illness like infections, inflammatory, etc. Diet modification, pre-operative fasting, very low calorie diets, post-operative reduced oral intake, so we should monitor the patient. We can stop for a period of time after surgery until we are sure that everything is stable. Medication change, pre-operative sodium glucose cotransporter inhibitor therapy, including continuing after surgery. This is a risk for euglycemic ketoacidosis. This is why we should stop them before surgery. Health system factors, misdiagnosis of type 1 diabetes, LADA, etc. So we should be cautious about euglycemic diabetic ketoacidosis whenever we prescribe sodium glucose cotransporter 2 inhibitor with the precipitating factors like intercurrent illness, diet modification, medication changes, and health system. why sodium glucose cotransporter 2 inhibitor use may be associated with euglycemic diabetic ketoacidosis. Euglycemic because there is glucosuria. This class of drugs leads to glucosuria and reduced sodium reabsorption. So reduction of glucosuria is concomitantly associated with increased ketone bodies reabsorption. So whenever we think of ketosis, here it's better to check plasma for plasma ketones and not for urine. Urine may be misleading. So this is a mechanism, increasing glucosuria and associated with increased ketone body reabsorption. Increased glucosuria leads to reduction of insulin and increasing glucagon, and increasing glucagon from alpha cell may be due to direct effect of sodium glucose cotransporter 2 inhibitors on these alpha cells, leading to increased glucagon. Combination of reduction of insulin and increasing glucagon are associated with the gluconeogenesis, ketogenesis, glycogenolysis, and increasing lipolysis. So all these lead to ketoacidosis. This is why whenever we suspect bizarre symptoms with the use of sodium glucose cotransporter 2 inhibitors, it is better to check the blood gases. If there is high anion gap acidosis with increased plasma ketone bodies, the treatment is to stop sodium glucose cotransporter 2 inhibitors and to give IV glucose and insulin. And IV intravenous glucose should continue until the ketones disappear. What are the causes of euglycemic diabetic ketoacidosis? Is it only sodium glucose cotransporter 2 inhibitors? This is the list of causes. So we have causes related to pregnancy, so enlarged using of glucose by fetus and the placenta, relative insulin deficiency, increasing production of fatty acid, converted to ketones in liver. So all these are causes related to pregnancy. Decrease the caloric intake, starvational ketosis. Decrease the caloric intake in patients with diabetes who continue taking of insulin may maintain euglycemia, but unable to stop the ketone body formation. Lipolysis and free fatty acid production are accelerated during fasting. And sodium glucose cotransporter 2 inhibitors, as I demonstrated, then glycogen storage disease, or other causes like pancreatitis, alcohol use, cocaine, intoxication, gastroparesis, Duchenne muscle dystrophy, insulin use prior to hospital admission, sepsis. So the list of the euglycemic diabetic ketoacidosis is very wide. Euglycemic diabetic ketoacidosis means we have ketoacidosis, but plasma glucose is near normal. So whenever we think, we check blood gases. If there is high anion gap, check for lactate. Normal, check the plasma for beta hydroxybutyrate. Elevated, give insulin and glucose. So this is the approach of management. If the lactate is high, we think of lactic acidosis and other causes of lactic acidosis. The question now, does sodium glucose cotransporter 2 inhibitors constitute an advantageous treatment? Is their use safe or unsafe? As you see here, the balance is tipped toward the beneficial effects. So sodium glucose cotransporters are considered among the best classes for cardiovascular disease because they reduce major adverse cardiovascular event, reduce cardiovascular mortality, total mortality, heart failure, coronary kidney disease, nephroprotective, and NAFLD. All these are advantages. And here, the disadvantages. So this is a call for individualization. So if the patient has active infection, genital infection, I will not prescribe sodium glucose cotransporter 2 inhibitors for patients with active infection or with volume depletion, acute kidney injury, if there is precipitation, euglycemic diabetic ketoacidosis, if there is precipitating situations like operations and stressful situation, bone fractures, the amputations, fournier gangrene, Here, both bone fracture and Fournier gangrene need to be confirmed. So they need to be tested further. So again and again, my opinion is the presence of sodium glucose cotransporter 2 inhibitor is a real advantage in management of type 2 diabetes, but we should be cautious in some patients and to monitor the patients against side effects. This is a report of 55 unique cases of Fournier gangrene. Fournier gangrene is necrotizing fasciitis in the preanal. This affects male and may affect females as well. And this is the data. 21 cases related to canagliflozin, 16 cases dapagliflozin, and 18 cases empagliflozin. Again and again. All these are observational data, and still the evidence is not confirmed. Regarding hypertension, I recommend this paper that is published in 22 pages in the Clinic Annals of Internal Medicine this month. It is a summary, a smart summary for the American guidelines. And here I'd like to stress upon the one of important issue is to respect lifestyle modification, because salt restriction, weight loss, aerobic exercise, DASH diet, limit alcohol, all these can be associated with significant reduction of blood pressure. And I recommend all of you to read this article in details, because it summarizes definitions, methods of diagnosis, the proper cuff size, and clinical guidelines for the use of antihypertensive medications. What about intensive blood pressure control? What does it mean? This means to reduce systolic blood pressure to a value less than 120 millimeter mercury. We should be cautious in diabetic, and we don't recommend intensive blood pressure control for diabetic patient. And this study shows that if acute kidney injury complicates intensive blood pressure control, this will be associated with increased mortality. And this is the editorial comment: blood pressure control, acute kidney injury, and cardiovascular event, separating the chaff from the wheat. This means we should monitor the patient well to think of kidney functions, and occurrence of acute kidney injury is bad news with the use of antihypertensive treatments. Regarding drug-induced hypertension, this is a nice mini review. Regarding cyclosporin, as we discussed in one of previous presentations, cyclosporin increases sodium glucose cotransporters within the distal convoluted tubule. So it stimulates sodium chloride cotransporter, leads to excessive sodium reabsorption. But it is not the sole mechanism of hypertension. The cyclosporin may lead to reduction of nitric oxide synthase activity, increased sympathetic nervous system activity, enhanced mitochondrial oxidative stress, increased endothelin, reduced prostaglandins, leads to all these mechanisms can amalgamate into increased sodium reabsorption, increased vasoconstriction, and this can lead to hypertension and as well nephrotoxicity. Regarding checkpoint inhibitors, this is one of interesting presentation, and this is checkpoint blockade in kidney transplantation, and I advocate just to review this videotape. So this is just a summary. This is a case, 74-year-old male renal transplant patient who developed lung cancer, non-small cell lung cancer, treated with nivolumab, which is one of the immune checkpoint inhibitors against program death-1. And consequently, the patient suffers from acute kidney injury, acute allograft failure. Creatinine increased from 0.7 to 7 milligram per deciliter, and the biopsy reveals severe fluoride rejection with C4D. So what is immune checkpoint inhibitor? This is the antigen-presenting cells, and antigen-presenting cells interact with T lymphocytes. This interaction leads to stimulation or inhibition of T lymphocytes. So we have accessories and receptors on antigen-presenting cell like BD ligand 1, program death ligand 1, that if this binds to program death 1 on lymphocytes, lymphocyte will be inhibited. And if we think of treating cancer, we like to activate T lymphocytes. So nivolumab blocks programmed Death1. And there are other drugs that block CTLA4 and others, and I'm not going to bother you by details for the checkpoint inhibitors. And this table shows different members of immune checkpoint inhibitors that are FDA approved for treating cancer. So this is the drug name, target pathway, and the cancer type that the drug is approved for its treatment. We should be cautious. Why we should be cautious? Because we stimulate immunity by immune therapy. And this may lead to cocktail of manifestations. So this class of drugs may be associated with aseptic meningitis, encephalitis, hypophysitis, uveitis, thyroid disorder, rash, thrombocytopenia anemia, hepatitis, pneumonitis, pancreatitis, so nephritis. So the system can, all body systems can be affected by the immune process. And to review this complications, you can go to this chapter. And the adverse events of using checkpoint inhibitor for treating cancer are classified into, the adverse events are classified according to severity into grade 1, grade 2, grade 3, grade 4, and grade 5 is death. So it is mild, asymptomatic, or mild symptoms, and here we can continue checkpoint inhibitors, but here we should evaluate the patient about stopping and use even immune suppressive therapy. And this is for renal side effects. Again, we have grade 1, this is the level of creatinine in grade 1, grade 2, grade 3, grade 4, and grade 5. And the management in grade 1, monitor renal function and quantify proteinuria, ensure hydration, discontinue other nephrotoxic drugs, exclude non-immune causes. So this is the management. If creatinine increased from 1.5 to 3-fold, consider hospital admission, hold checkpoint inhibitor therapy, exclude other causes, and consider using steroids. If the adverse event grade 3, admission for IV hydration, holding checkpoint inhibitors, given steroid in this dose. If grade 4, as grade 3, but give solomidrol infusion and then prednisolone. So this is one of the interstitial nephritis complicating with checkpoint inhibitors, and this is one of the update of how to deal with acute kidney injury in case of checkpoint inhibitors. So if the cancer patient receives immune checkpoint inhibitors and then the situation is complicated by acute kidney injury, we evaluate acute kidney injury. Is it stage 1 and acute kidney injury resolves? Continue immune checkpoint inhibitor therapy. If acute kidney injury progresses, stop immune checkpoint inhibitors. And usually we re-evaluate after 1 week and continued monitoring of the patient. If the acute kidney injury progress, here nephrology consultation. And nephrology consultation, if the acute kidney injury is stage 2 or 3 from the beginning, start nephrology consultation. And here we evaluate the patient. If after referral to nephrology, then AKI potential due to immune checkpoint related nephrotoxicity, no immune related adverse events, bland urine, and here so kidney biopsy is needed because there is no data of acute tubular injury. So kidney biopsy may show acute tubular injury or other non-acute interstitial nephritis. Restart immune checkpoint inhibitor when acute kidney injury resolve. Acute interstitial nephritis, treat with steroids, and restart immune checkpoint inhibitors when AKI resolves. If there is organ immune related adverse event and sterile biuria and or white cell class, treat with steroids. If here acute kidney injury due to non-immune checkpoint inhibitor toxicity, like the presence of urinary obstruction or other cause of acute kidney injury, treat the cause and restart immune checkpoint inhibitor whenever acute kidney injury resolves. the challenge of the use of immune checkpoint inhibitor in transplantation is when we stimulate immune cells, rejection may occur. This is the problem. This is why the use of immune checkpoint inhibitors in organ transplantations is still on case reports. So 29 cases in renal transplant patient, 19 liver transplant patient. And the question is to use or not to use immune checkpoint inhibitors. We should individualize our management according to the nature of the tumor, its response to checkpoint inhibitors, and the patient outcome. If mortality will occur if we don't treat cancer, it's better to treat cancer. And we even use steroid therapy with the treatment of immune checkpoint inhibitors with renal transplantation. So again, it is an individualization, and we need further evidence for the safety of the use of immune checkpoint inhibitors in the case of transplantation. From the new publication, this is very interesting. The use of hydroxychloroquine and the effects of hydroxychloroquine on proteinuria in IgA nephropathy. It is a randomized controlled study where hydroxychloroquine is compared to placebo. Each group included 30 patients. It's a double-blind, randomized, placebo-controlled phase 2 clinical trial. And this study shows that use of hydroxychloroquine plus the patient was treated by maximal RAS blockade, and then hydroxychloroquine or placebo are added. Here, in comparison to placebo, the reduction here, this is the percent of patient with 50%, more than 50% reduction in 24-hour proteinuria. Here, this is after in the month 2, significant difference. Month 4, significant difference. So the use of hydroxychloroquine is associated with significant reduction of proteinuria. So this is very interesting news, because using this antimalarial may constitute a step whenever we have proteinuria and the patient was treated with a maximal dose of RAS blockade. We can add in IgA nephropathy, especially if the patient cannot tolerate steroid, if there is infection, because yes, hydroxychloroquine is an immune modulatory, reduces toll-like receptor and autoantigens, but it is not associated with significant immune suppression. So if there is a risk of infection and we use the maximum RAS blockade, we can think of hydroxychloroquine, but we are waiting further studies. Another interesting point, fluconazole, which is antifungal drug. What is the effect of fluconazole here on osmotic water transport in renal collecting duct through the aquaporin trafficking? So this is the V2 receptor. Fluconazole doesn't affect the V2 receptor, so it is independent on AVP. So it localizes aquaporin channel to plasma membrane of principal cell and affect this structure and actin. So it leads to liberalization of the vesicles of aquaporins to enhance water reabsorption. So again, will we use this drug in the future for cases of nephrogenic diabetes insipidus to stimulate water absorption? I don't know. We are waiting further studies, but it is a good hypothesis done on experimental study. The final message is drug prescription in any specialty is our responsibility as doctor, and we should be responsible. And whenever we start medicine, we should be smart, trying to minimize drug as we can, because a great doctor is a doctor who can treat many diseases or many situations by one drug. Drug is there in the food, in the drink, in medicines. So we should be careful whenever we advise the patients to be advised on knowledge and experience. And I think it's now we have all resources. This is a very nice resource for education and for topics. And even we can use, as I mentioned before, the sites for interactions like Liverpool, the smartphones and anything. And we shouldn't say without revision, because whenever we answer without knowledge, this may put the patient in harm. Again and again, we need more and more education. A doctor is a student until he dies. Once he considers himself not a student anymore, the doctor inside him dies. This is the end of this presentation. Thank you for attention. And if you have any questions, please don't hesitate to send to my email. Thank you and goodbye.